This program is brought to you by Emory University.
It's a great pleasure for me to introduce a friend of mine from many years ago, Dr. John Brush. John earned his medical degree from the University of Virginia and then trained in medicine at Vermont School of Medicine and then in cardiology at Yale. In the mid to late 80s, he and I were senior investigators in the cardiology branch at NIH. And that's where we worked for several years and wrote several papers together. And then he saw the light and moved to Norfolk after that and has been there ever since. And he became chief of the cardiology section at Eastern Virginia Medical School and is professor of medicine at that medical school as well currently. He's now the senior medical director for Centara Health Research Center and has a busy clinical cardiology practice. But over the years, he's worked very much in the field of quality initiatives and cardiovascular health outcomes research, and has a few years ago authored a book called The Science and Art of Medicine, A Guide to Medical Reasoning. And this is what his subject today is going to be about, is Guide to Medical Reasoning. He is serving as on the board of trustees at the ACC and has, as I said, led a number of quality improvement initiatives. Also works with the Board of Internal Medicine and Cardiovascular, ABIM. So John is going to talk to us about the art of diagnosis and examination of diagnostic reasoning. I think it's a new subject for all of us. And thank you very much, John, for doing this.
Thank you very much, Arshad. It's a real honor and privilege to speak to you this morning. And it's great to reconnect with my old friend, Arshad. After all these years, many years ago, we had such a good friendship and collaboration at NIH. So it's a pleasure to be here this morning and join you in your conference. So I'd like to talk about diagnosis and diagnostic reasoning this morning, some of the, just some background, but also some of the research that I've been able to do in this area. Let me see if I can make sure that, there we go. Disclosures, as Arshad mentioned, I wrote a book, The Science of the Art of Medicine, Guide to Medical Reasoning. The iBook is free, actually, but I do receive a small amount of royalties from the book sales through Amazon. My learning objectives are to understand the diagnostic process, to understand the variation in symptom phenotypes for acute myocardial infarction, and to understand differences between women and men in symptom phenotypes of acute myocardial infarction. So research in cardiology primarily focuses it doesn't really focus on diagnosis, I would say. What's kind of cool in cardiology are the randomized controlled trials. They are prominently displayed in medical journals, particularly the cardiology journals. Things that are therapeutic interventions are picked up and widely discussed and in the cardiology community, particularly in the subspecialty groups of the cardiologists. Certainly anything that has any kind of commercial application has also the marketing of behind it and what have you. So research related to diagnosis is sort of less cool. It seems to be obscured a bit. But actually, it's hiding in plain sight because there's been abundant amount of research in how people make diagnoses, but it's primarily hidden in academic journals, medical education, academic medicine, those type of journals that aren't widely read by clinical cardiologists. And yet clinical cardiologists are the ones who are teaching medical students and residents, trainees at all levels, how to make a diagnosis. So it's sort of a curious disconnect. I'll just make a shameless plug for a review that is coming out in the British Medical Journal. It's in the production stage now, so it should be coming out in the next several months. The Heart of Diagnosis and Evidence-Based Review of Diagnostic Reasoning in Cardiovascular Medicine. I was invited to write this review, And I reached out to Jonathan Sherbino and Jeff Norman at McMaster University to write this with me. So that's coming out soon. And so I'd like to make you aware of that. There was a lot of public attention drawn to the whole thing about medical error. In 2000, the year 2000, the Institute of Medicine came out with this book, To Err is Human, and it made a big splash. It talked about some 90,000 people that die each year because of medical error, and it made quite a splash. A little bit less of a splash is the book on the right, Improving Diagnosis in Healthcare. This was also published by the Institute of Medicine and talking about diagnostic error. So there has been some attention drawn to the topic of diagnostic error. Certainly the way we make a diagnosis and the way we reason has been influenced by a general increase in attention towards cognitive psychology. Daniel Kahneman's book, Thinking Fast and Slow, was a New York Times bestseller. Daniel Kahneman is a Nobel Prize winner in economics and a professor of, and basically the inventor of the field of cognitive psychology, or one of the founders of the field of cognitive psychology. He's a professor at Princeton. Dan Ariely from Duke wrote this book, Predictably Irrational. We actually aren't rational as we would like to think, but in fact, we are predictably irrational, and figuring those predictably irrational characteristics of our thinking is what cognitive psychologists do. So about 10 years ago, I got very interested in this. As Arshad mentioned, I was involved in quality improvement with the ACC. And I really started asking, what causes people to make errors and what causes people to make good decisions? And I stumbled on the field of cognitive psychology. When I took psychology many years ago in college, the field of cognitive psychology really didn't exist. It was behavioral psychology primarily. So I started reading Daniel Kahneman's papers and the papers of other people. And I started, after reading this literature and noticing how this is the science of decision making, and doctors make decisions every day, and yet doctors don't know about cognitive psychology. They don't learn about it in medical school. Seemed like a disconnect. And so I started telling my wife, I could write a book on this stuff. And so ends up I did. I wrote this book, The Science of the Art of Medicine. And then subsequently, I was invited to write a chapter in Brownwald. The third chapter in Brownwald is on decision-making in cardiology. I was invited to write that and co-authored that with Harlan Krumholtz. We just finished an update of that for the 12th edition, which is coming out in November. So why do we have to think about medical reasoning? Why do we have to reason things through? Why can't we just follow the rules? It's because there is uncertainty, and there's a lot of uncertainty in what we do daily. Philosophers say that there's actually two types of uncertainty: stochastic uncertainty, related to chance, variation, and randomness, and epistemic uncertainty related to knowledge or lack of knowledge. We don't know the true state of a patient when we see the patient initially. And all of us have a lack of medical knowledge, either a personal lack of medical knowledge because no one person can know everything, or collectively we may not have the knowledge just because it's an area that has not been discovered or has not been researched adequately. So stochastic and epistemic uncertainty. To give a sort of an estimate, a quantitative estimate of how much uncertainty we deal with, I'll just point out an article that was published by Tricocci et al. In JAMA in 2009. Tricocci was at Duke at the time. And what they did is they examined the 16 cardiology guideline documents that existed at that time. And in those 16 guidelines, there were a total of 2,711 recommendations. Ends up, they found that only 11% of those recommendations had an evidence level of A. Almost half of them had an evidence level of C, meaning it was just simply opinion and not based on any evidence at all. And so if you think about it, evidence-based medicine is just a small portion then of our guidelines, but guidelines are a small portion of what we do in clinical medicine. So you can sort of do a back of the envelope calculation and figure out that maybe about 5% of what we do, 5% of the decisions that we make on a daily basis are actually rule-based. And approximately 95% of those decisions are actually intuitive. So that kind of matches up with something that Gary Klein, a cognitive psychologist who's written extensively about how we use intuition, he came up with sort of the same general proportion of decisions that are made intuitively. So what exactly is intuition? When cognitive psychologists talk about intuition, they're not talking about guessing. The common use of the term is kind of guessing or what kind of comes to mind. But for cognitive psychologists, it's non-analytical reasoning. And for a good definition that's really relevant, I think, to diagnosis, I'll turn to Herbert Simon. Herbert Simon is one of my heroes. He also won the Nobel Prize in Behavioral Economics because he was also one of the founders of cognitive psychology and behavioral economics. He was actually a computer scientist at Carnegie Mellon, and he was trying to figure out how to make computers think like humans, but in the process really learned a lot about how humans think. So he said this, he said, "The situation has provided a cue. This cue has given the expert access to information stored in memory, and the information provides the answer. Intuition is nothing more and nothing less than recognition." So how can we improve diagnostic accuracy? This is a quote from W. Edwards Deming, who, as many of you know, was an engineer who was very instrumental in teaching the world how to improve manufacturing and other quality aspects of industry. He said, "If you can't describe what you're doing as a process, you don't know what you're doing." So what is the process of making a diagnosis? About 3 decades ago, 3 groups working independently, Dr. Elstein, Jerry Kassir at Tufts. Elstein was at Michigan State. Jerry Kassir was, you may remember, he was the editor of the New England Journal for years, and he was at Tufts. And Barrows and my friend Jeff Norman and other investigators at McMaster, they figured out that the process of diagnosis is a 2-step process. It's a process of hypothesis generation and hypothesis testing. And in going through that 2-step process, people use both types of reasoning, system 1 and system 2 thinking. So the system 1 and system 2 thinking, it comes from this thing called dual process theory. It was initially defined by Jonathan Evans from Great Britain, but then Daniel Kahneman has done extensive research along with his research collaborator Tversky, and so that's basically what thinking fast and thinking slow is. So system 1 is the intuitive mode. System 2 is the analytical mode. System 1 is fast and automatic. System 2 is slow and deliberate. System 1 is sort of like driving down the highway. You arrive at your destination, you don't even know you got there, but you were making lane changes and turning your turn signal on and making adjustments, all without thinking. Whereas system 2 is sort of like parking in a tight space where every move is deliberated on and slowly and deliberately thought through. System 1 loves associations, loves stories. System 2 uses explicit beliefs and reasoned choices. System 1 sees the forest. System 2 sees the trees. You would think that system 2 would be the mode of choice for doctors trying to think through problems, but ends up system 2 can be too slow and system 2 can't handle uncertainty. So we oftentimes resort to system 1. It can be biased, but it's often correct. So ends up, we have 2 modes of thinking, and according to Herbert Simon, that's because there are 2 types of problems. Unstructured problems, shown on the left, and structured decisions, shown on the right. Unstructured problems are like a pile of jigsaw puzzle pieces, and this is sort of similar to running into the emergency room and seeing a patient. You have all kinds of scattered pieces of information that are thrown your way. And your job is to sort through those pieces of information, similar to sorting through and looking for the edge pieces and sorting by color, sorting the pieces of a jigsaw puzzle. But analytical thinking is used for structured decisions where you're at the point in a trail where you can either go left or you can go right. It's either A or B. It's either acute myocardial infarction or not. We try to turn unstructured problems into structured decisions that we can test. So what about this idea of early hypothesis generation? What can we learn about this? Again, these early investigators figured out that expert diagnosticians have 3 to 5 diagnoses in their head within seconds to minutes after starting a diagnostic encounter. And if the diagnosis is recognized early on, it's associated with about 95% accuracy. Whereas if it wasn't recognized early on, the diagnostic accuracy fell to about 25%. So early recognition, early hypothesis generation is very important. Early hypothesis generation is not coming to conclusions. It's not jumping to conclusions, but it's recognizing the diagnostic possibilities. Ends up early hypothesis generation evolves as we go through training. Students just after their preclinical years don't have any clinical experience. They have a lot of knowledge about how the body works and anatomy and physiology and pathophysiology. And so they use mechanistic or causal reasoning. And as we all know, when you have new students that come on the wards and they work through problems, it's a bit clunky. But as students gain experience and then as they become residents, they start to use something called illness scripts, where they add to their mechanistic reasoning and their knowledge about the mechanisms of diseases. They add to that actual experience, and they encapsulate that experience into illness scripts, which are idiosyncratic memories of or concepts of diseases that are associated with either a prototype or maybe even an exact example of that particular disease. But as people gain more experience and as people become experts, they start to use something called exemplars. Anytime you see an object and you label that object and you put that labeled object in your long-term memory, that's called an exemplar. And so that's what we do. We remember examples over and over again, and that's called experiential knowledge. So that enables us to use non-analytical reasoning or intuition. So when I show you this picture, you know that you're looking at chairs. You don't go through a rule-based algorithm and say, okay, it's these things have legs, they've got seat cushions, they've got arms. You don't do that. You just know. And you know because you've seen a gazillion chairs. And so you know that all of these are chairs, even though some of these are very atypical presentations of chairs. You just know. And it's an immediate, effortless process of recognizing a chair. Ends up, expert clinicians do the same thing. You go to the emergency room, you see a patient with sepsis, you just know. You may not know that conclusively, but you know that it's clearly a possibility. Acute myocardial infarction, COPD exacerbation, heart failure exacerbation. You can just look and you just know. With exemplars, the recall is effortless. And the number of exemplars that you have in sort of your file cabinet of long-term memory gives one an intuitive sense of the base rates of diseases and the range of variation within disease categories. So there's exemplar theory, but there's also another theory called prototype theory. Exemplars are it's an instance-based model with immutable examples, and there's no abstraction involved. You remember exactly what you remembered. Whereas prototypes are a set of weighted features. It's a summary description. It's a concept. There's some abstraction involved. And this is what's typically presented in textbooks. The Netter drawing on the right gives an idea of this. I would say the prototypical example of an acute myocardial infarction is a patient with chest pain radiating to the neck or the arms, associated with shortness of breath and diaphoresis. That's the prototypical example that's given in textbooks. I think you'll agree. So we're going to get back to that in a second. So I had the opportunity to look at this and examine the variation in how people do present with acute myocardial infarction, and to think about exemplars, because I participated in an NIH-sponsored registry called the Virgo. It was an NIH-sponsored registry that was led by Harlan Krumholtz and other investigators, Judith Lichtman and others at Yale. And I was the local PI on this in Norfolk. The registry signed up 3,501 patients who were hospitalized with acute myocardial infarction. And this particular registry was primarily interested in the presentation of young women with acute myocardial infarction, hoping that if we got enough young women to look at, we would notice what's unique about that particular subset of patients with acute myocardial infarction. And so by design, they signed up with a 2-to-1 women to men enrollment ratio, and patients were less than 52 years old. So the Virgo analysis, what we did is a secondary analysis of the Virgo data. And so I was able to team up with 3 Yale investigators, Rachel Dreyer, Eric Green, and Harlan Krumholtz. And so here's the background. As clinicians, we see individual patients, and we remember those individual patients as exemplars, as I pointed out. So what is an exemplar? It's simply a mental representation of a specific phenotype. And so we get the idea of specific phenotypes. We collect specific phenotypes in long-term memory. And so question is, how do features combine as individuals as specific phenotypes? And do the features combine differently in women than men? And do features combine differently in acute myocardial infarction subgroups? So one of the great things about the Virgo study is that all of those patients had an interview with a study coordinator. And that study coordinator very carefully and completely recorded the presenting symptoms. They asked specifically about 10 symptoms, and those are listed on the left. And so theoretically, if you try to figure out how 10 of anything combines, you can come up with 1,023 different combinations. And so these phenotypes are like snowflakes with a bunch of unique combinations of symptoms in individual patients. Typically, what we do is we look at symptoms and how they aggregate at the population level, and what are the population means of symptoms. We don't look at them at the individual levels, but this shows what the Virgo study found at the population level. Like most studies, they found that chest pain was the most common symptom, and chest pain was more common in men than women. Although in this particular study, that wasn't statistically significant. Whereas a number of other studies, indigestion, nausea, radiating pain, shortness of breath, palpitations, were all more common in women at the population level. So what I was able to do, they sent me a limited data set of the Virgo data, and I loaded this up in a statistical program called JMP, JUMP, made by SAS. And so I was able to concatenate the symptom columns into symptom strings. And so the computer then recognized each one of those symptom strings as a unique phenotype. And that enabled us to figure out what the phenotypes were. And so here is just a sort of a brief description of the distribution of the phenotypes and part of the phenotypes. And you can see that chest pain alone was the most common phenotype, occurring in about 5% of the population. Chest pain with radiation was second most common. Chest pain with shortness of breath, third most common, and so on. What we found is there were 488 unique symptom phenotypes in the Virgo study group of 3,500 people. And there were 426 phenotypes in women and 280 phenotypes in men. So it looked like substantially more in women than men, but remember, the study signed up women and men on a 2-to-1 enrollment ratio. So we don't know yet whether that is meaningful or not. Here are the top 25 unique symptom phenotypes by sex, and you see the women on the left and the men on the right. And just to summarize, I'll tell you that the two top are the same, chest pain and chest pain with radiation. The top 6 are the same, but in different order. And 6 out of the top 25 don't match in males and females. You can see the table down at the bottom that among the top 25, they were more heavily concentrated among men than women. Women were more spread out beyond the top 25 than men. So this gives you an idea that, you know, women and men, there's a difference between women and men. This is a mosaic plot where each one of these stripes is actually one of the phenotypes. And you can see that, first of all, the columns are twice as tall for females than males because of the 2-to-1 enrollment ratio. But you can see the relative distribution of the phenotypes in women and men. And you can see, I mean, you can just glance at it and you can see that there's something different about women and men here. Unfortunately, we couldn't do just a chi-square analysis because of the sparsity of data in most of those cells, but you can see how things are distributed here. And I'll just show you the arrow there shows the prototype. That's those green stripes are that chest pain radiating with shortness of breath and diaphoresis. And you can see that the prototype is a relatively uncommon phenotype. So this is how the distribution of the phenotypes it looks. It's a distribution with a very, very long tail with cells that are very, very small and yielding, and you can see that, this tail goes way off the screen to define the description. So how can you analyze this statistically? Our statistician was Eric Green, and he informed us that because of the 2-to-1 male to female enrollment ratio and the way that things are distributed, the best statistical analysis would be a Monte Carlo permutation testing. This is where we randomly permuted sex to create 99,999 data sets under the null hypothesis that sex doesn't account for the excess in phenotypes in the larger group, but it was simply because it was a larger group. And so the p-value is the portion of that empirical distribution showing a difference is large or larger than the original data. So what we found is that the difference of 146 phenotypes between women and men was in fact statistically different than the median difference that would have been expected, the median difference of 110 that would have been expected simply because of the difference in numbers of women and men, highly statistically significant. So we also did another type of statistical analysis. We did repeated subsampling. And so here, this shows the distribution of the number of interview symptom phenotypes in women and men from 100,000 subsamples using a bootstrap sample size of 500. And you can see here that analyzing it this way, there were statistically many more. The mean was 206 phenotypes in women versus 187 phenotypes in men, statistically significant. Furthermore, 42% of the interview symptom phenotypes, constituting 21% of men, were only present in men and not present in women. This is with the subsampling technique. Whereas 47% of the interview symptom phenotypes, representing 26% of the women, were present in women and not present in men. So in addition, at the population level, on the average, women had more symptoms than men. There were on the average 4.3 symptoms per woman versus 3.9 symptoms per man on the average. And the probability of the overlap in the interview symptom phenotypes in women and men decreased as the number of symptoms in the phenotypes increased. For the overlap, the odds ratios accompanying a 1 symptom increase were 0.85 for women and 0.94 for men, both statistically significant. This slide shows various subgroups of acute myocardial infarction. And you can see that in all subgroups, so what you're looking at here, you're looking at just basically the distribution of those subgroups in women and men in the first 2 columns. But in the third column, this is the observed difference between the subgroups. In the 4th column is the difference that would be expected under the null, and the 5th column is the p-value. So in many of those subgroups, the statistical significance remain, but it was interesting that in patients with non-STEMIs, patients who did not receive an acute PCI up front, patients with atypical chest pain, and patients with who presented greater than 6 hours of chest pain, the statistical significance disappeared. And it was as if the number of phenotypes in men sort of caught up with women in those groups of those subgroups where maybe the diagnosis is a little bit more ambiguous than STEMIs and patients with typical chest pain, or for example. So we published this last year in cardiovascular, in Circulation, Cardiovascular Quality and Outcomes. We had a second opportunity to do a similar study in another NIH-sponsored registry called the Silver AMI study. This was also a Yale-sponsored study that was led by Sarwat Chaudhry. So we approached Sarwat about this, and she agreed to do the study, and Ali Hadjic joined us, and you can see Rachel and Harlan and Eric work on this as well. So we basically repeated the study, but in the Silver AMI study, rather than having 10 symptoms to look at, they actually asked specifically about 22 symptoms. But it was a similar situation where a coordinator very, very completely wrote down every symptom. So it was really a good opportunity. There was no fallout. You know, if we were looking at the medical record, there would be fallout for a number of reasons where symptoms may not be reported in the medical record, but there was no opportunity for fallout. So with 22 symptoms, theoretically, there are over 4 million different ways that these 22 symptoms can combine into individual phenotypes or snowflakes. So in this study, what we found is there was a total of 1,469 different symptom phenotypes. There was more in women than men, and the difference was 12, 831 in women, 819 in men. I'm just showing you the top 10 phenotypes here. Top one in this situation again was chest pain alone in 5% of women and 11% of men. And down at the bottom, again, the same thing. The top 10 phenotypes were more heavily concentrated in the top 10 in men, but more spread out in women, more spread out among a larger number of phenotypes. So we had the same situation, only it was reversed. There was no 2-to-1 enrollment ratio in the Silver AMI study. They just enrolled patients as they came in. And so not surprisingly, there were more men than women in this study. And so the enrollment ratio was reversed. And so we had the opposite problem, but we still needed to do the Monte Carlo permutation testing to overcome that problem. And so what we found is that difference of 12 phenotypes, 12 more phenotypes in women than men, was very highly statistically significant, because you would have expected 158 more phenotypes in men than women given the enrollment ratio, which is kind of interesting because typically in any kind of study of acute myocardial infarction, you're going to have more men than women. And so, you know, it just raises the question, what else is hiding? Because perhaps, you know, the analysis was dominated by the greater number of men in a population. But this particular type of analysis was able to reveal that women had more symptom phenotypes than men. Again, with a repeated sampling, the distribution of the number of interview symptom phenotypes in women and men from 100,000 subsamples using a bootstrap sample size of 500 showed that women had significantly more phenotypes than men. And again, repeated subsampling showed that 82% of phenotypes, constituting 62% of women, were only in women, and 80% of phenotypes, constituting 52% of men, were only in men. The differences were more extreme in this one because there were more phenotypes, and there were more phenotypes because they collected more information on more symptoms. And so this all makes sense. Here are the subgroups in this study, and almost all subgroups, whether STEMI or non-STEMI, delay, PCI or no PCI, almost all of the subgroups were statistically significant. One that was not was in Hispanic patients, but the sample size was very small. We did look at the relationship between mortality and in those, again, the sample sizes were very small. and the differences between women and men did not reach statistical significance in those subgroups. This is a little bit busy, but it shows the rates of symptoms in women versus men at the population level. And at the population level in this study, men did have chest pain more often, statistically significantly more often than women. But there were a number of different other symptoms that were reported more commonly in women. And I'll just summarize this in the next slide. Only chest pain was more common in men, but there were 8 other symptoms that were more common in women. All of the radiations, nausea, vomiting, indigestion, diaphoresis, they were all more common in women. The top 4 symptoms in both women and men were chest pain, shoulder or arm pain, dyspnea, and weakness. So if one were to construct the prototype for elderly people, you would substitute weakness rather than diaphoresis potentially as your prototype. So what about prototype versus, what about this prototype? Perhaps a prototype is actually a stereotype. The classic prototypical description, as I mentioned earlier, of a patient with acute myocardial infarction is a patient with chest pain radiating to the arm or neck with shortness of breath and diaphoresis. What percentage of the Virgo and Silver AMI patients had that prototypical constellation of symptoms? Only about 1%. So if you're looking for that particular phenotype, you may be, and thinking that that's the common phenotype, you may be looking for a stereotype because it's actually a very uncommon phenotype. The classic prototypical description is typically the combination of the 4 most common symptoms at the population level, but that phenotype is rare. But still, about over 90% of both women and men and over 90% of the phenotypes had 1 or more of those top 4 symptoms. So using the prototype as a memory aid, perhaps, for trying to remember the most common symptoms may be a useful way to look at the prototype. But if you're looking for that prototype as a phenotype, that's not a very good strategy. Just one other reminder, for older patients, the top 4 symptoms included weakness rather than diaphoresis, which was an interesting difference between the classic prototype and the older people. So just a summary, and so this information now has been accepted for publication in the American Journal of Medicine and will be coming out in publication in March. To summarize, there's an enormous variability in symptom phenotypes in acute myocardial infarction patients, both in young patients in the Virgo study and the old patients in the Silver AMI patients. And examining distributions of phenotypes rather than distributions of symptoms at the population level may be revealing. I think it would be fascinating to see if we were able to get a hold of a database where you could look at the same thing in patients with shock, for example, or with septic shock, with sepsis. What are the phenotypes in those? And perhaps that would be revealing and help us make a diagnosis more readily in diagnoses that are particularly challenging. Women have significantly more variability than men. Women have more variability in almost all subgroups. Women reported more symptoms resulting in the added phenotypes. This may have implication for improving diagnostic reasoning, may help quantify how much experience is needed in training to sort of get your head around the extent of variability that you would be expected to see in practice. And it may partially explain the misdiagnosis in women. It may have implications for gender disparities. In general, heart disease is underdiagnosed and undertreated in women. Younger women with AMI have twice the mortality rate than men. Now, it's very difficult to figure out the rate of misdiagnosis and to compare the misdiagnosis rates in women and men. And I'll tell you why. It's just like errors in baseball. It's easy to count the errors, but it's hard to come up with an error rate because it's hard to figure out that baseline, the denominator. What is the denominator for diagnostic encounters that you would use? Is it all patients in the emergency room? Is it all patients with chest pain? Because that doesn't sound good because many of the ones that would be missed actually probably don't have chest pain. So how do you define the denominator to come up with a rate? I could only find one study, a study from the ACI-TIPI study reported in the New England Journal, that gave a misdiagnosis rate and compared women and men. And it looked like it was roughly double in women than men, but it's very hard to think about. But nevertheless, I think that it's quite possible that the error rate, the misdiagnosis rate, is higher in women than men. And it could be because of the variation in symptom phenotypes. That could create diagnostic confusion, leading to misdiagnoses. The added symptoms could be distractors. Palpitations, for example, is more common than women. Could be a distractor rather than something that leads people to the diagnosis. So having an awareness that there's greater variability in how actually those symptoms combine at the individual level is much more variable in women than men, could possibly help people make the right diagnosis more commonly. So how about the second part of the diagnostic process, the hypothesis testing? So I'll just shift gears just a little bit to talk about another study that I did to evaluate this part of the process. The second part of the process is basically Bayesian reasoning, where you're taking new information, the information from a test, and you're incorporating it into your old information to come up with a new conclusion. So the question we asked is, can you actually teach Bayesian reasoning? This started with a discussion that I had after I wrote my book with Jeff Norman at McMaster University, and I thought that it could. That was why I wrote my book. And he was a bit skeptical. So we decided that we would put together a randomized controlled trial. We had conducted a randomized controlled trial of medical students at McMaster University and Eastern Virginia Medical School. And these medical students were randomly allocated to one of three conditions. One was a video, an 18-minute video of me teaching the concepts of Bayesian reasoning. The second was a group, the second group were shown 27 examples of diagnoses and how they sort of played out and what was the final probability assessment after testing. And we gave them examples of pulmonary embolus, congestive heart failure, and acute coronary syndromes to give them some experience, thinking, and Jeff thought that, that experience would be adequate to give them some general sense of how Bayesian reasoning worked. And then the third group was the control group that got no instruction or no video or no examples. They simply had some reading material about the particular diagnoses. And at the end, we gave the participants a quiz of 20 questions. We asked them what was the pretest probability of a particular diagnosis. We didn't ask them to come up with a diagnosis. We said, what is your pretest probability of pulmonary embolus or heart failure? And then based on their pretest probability, then we calculated what the post-test probability should have been based on Bayes' rule. And we compared the calculated post-test probability with what they thought their post-test probability was. And so our measurement was how far was their estimate of post-test probability from the calculated value. So this is a consort flow diagram of the study. We sent out email solicitations to students at both schools. 65 responded and were randomized. Of those 65, 61 completed both the learning and the testing, and they were fairly well allocated to the three groups. So what did I talk about in this 18-minute video? What were the concepts? First of all, I talked about the order of operations. The order of operations is hypothesis generation, then hypothesis testing. And that's important. Just simply starting with the testing without any consideration of what you're looking for is generally a bad idea. And so in addition, in terms of adding a probability element to this, we talked about something that the cognitive psychologists call, it's a heuristic called anchoring and adjusting, where you anchor your pretest probability to a particular number, and then based on new information, you adjust. So this is an intuitive way of doing Bayesian reasoning. And it identifies two fallacies. If you don't first anchor a probability estimate, you can commit the fallacy of base rate neglect. And if you don't properly adjust after getting new information, then you can commit the fallacy of anchoring. So learning about the anchoring and adjusting heuristic was something that was discussed. So how much should you adjust your probability estimate based on new information? We use likelihood ratios to give people an idea of how much to adjust your probability to come up with a post-test probability. So order of operations, anchoring and adjusting, and likelihood ratios were the three concepts that I focused on in my video. So anchoring and adjusting, this sort of shows what that's all about. On the x-axis, you come up with an anchor, your prior probability, and based on that, depending upon whether the test was negative or positive, you adjust. You make an adjustment, and then you can go over to the y-axis to read off your posterior probability, post-test probability. Likelihood ratios were what we were trying to convey as ways that you can think about how much to adjust. And as you remember, a likelihood ratio is the percentage of disease patients with a given test result divided the percentage of non-disease patients with that same test result. So for positive likelihood ratio, it's the true positive rate divided by the false positive rate, or sensitivity divided by 1 minus specificity. And for a negative likelihood ratio, it's 1 minus sensitivity divided 1 minus specificity divided by sensitivity. And so one of the things that's also curious is that these likelihood ratios can be asymmetric. Congestive heart failure on a chest X-ray to come up with a diagnosis of heart failure, the positive likelihood ratio is incredible. It's 13.5. Whereas the negative likelihood ratio is really kind of bad. It's 0.48. So a likelihood ratio of 1 is worthless, right? It doesn't change how you think. Anything going up is a positive likelihood ratio. The farther away from 1 is better. And for a negative likelihood ratio, that's a fraction. The farther away from 1 is better. So for congestive heart failure, you can see on the right, you can see a graphic that shows that positive likelihood, a positive test should shift your thinking much more. And why is this? This is can be remembered because by the mnemonic SPIN. Congestion on a chest X-ray for heart failure is highly specific. So if a test is highly specific and it's positive, it's good for ruling something in. Whereas D-dimer for pulmonary embolus has a pretty crummy positive likelihood ratio, but a very good negative likelihood ratio. So it's asymmetric in the other direction. And that's because it is highly sensitive. And so a test, this can be remembered by the mnemonic SNOUT. A test that's highly sensitive, if negative, is good for ruling something out. These are the concepts that these students were taught. So can you teach medical reasoning? We gave them a quiz of 20 questions to ask them what their post-test probability was. And the questions were related to those 3 diagnoses in the learning examples: pulmonary embolus, heart failure, and acute coronary syndrome. But we also included some questions related to a new diagnosis, pneumonia, to see whether there was transfer of concepts to a new diagnosis. And so the issue was, how far was the post-test probability estimate from the calculated value? So surprisingly, we found that all students did much better than expected. The literature has indicated that, that students are wildly off in this whole thing. Arshad may remember there was a study many years ago that it was actually a letter to the New England Journal by our old friend Trip Cassels about how bad students and residents were at Harvard in coming up with a post-test probability. But you can see, just focus on the column all the way to the right. This is among negative test results and positive test results. On the average, the students were pretty close to the calculated post-test probability. But how close were they to the mark? There was the students that were randomized to receive the video of the concepts of Bayesian reasoning did statistically better than patients who were given the examples or the control group. And so if you separate them out according to the ones who got the learning, the same diagnosis, the acute myocardial infarction, pulmonary embolus, and heart failure, versus the new diagnosis, pneumonia, the subgroups started to get pretty small. There's certainly a trend with the learning group, but there was quite a significant difference in the new group, suggesting that there was transfer of concept to a new diagnosis, and they grasped the concept. This is all done on a computer, and so we were able to time the responses. The people that were randomized to the concept group did have a longer time, but it was not that long. On the average, it was roughly 25 seconds. So there was clearly not enough time where they were taking out a pen and pencil and actually calculating the doing Bayesian calculations. But it was a little bit longer, as if they were, thinking through the concepts more than the experience or control group, which on the average spent 10 seconds coming up with the answer. So conclusions from this study: all study participants did better than expected in estimating post-test probability. Instructions on concepts of Bayesian reasoning and how a Bayesian update can be used improve participants' ability to estimate post-test probability. And the effect of the instruction appeared to transfer from familiar cases to new cases. So we can conclude that reasoning can be taught. It's consistent with some of the literature, although a lot of the literature is a little negative on this, but we think that in fact Bayesian reasoning can be taught with some improvement in diagnostic reasoning. So this was published in JAMA Network Open last year. So what are the take-home messages for diagnostic reasoning? One, I think, based on the studies that we did looking at exemplars, and something that I tell students and residents: make the most of your experience. That experience is really important. Experiential knowledge is what differentiates an expert from a novice is knowledge. And knowledge exists both in experiential knowledge and formal knowledge or propositional knowledge. That experiential knowledge is really, really important. And it's really stored in instances. Instances of objects are stored as exemplars. So seek feedback and try to label patients with a diagnosis to create a good store of exemplars in your long-term memory. The variation in symptom phenotypes is greater in women than men. And so be aware of that. Be aware that you need to think more expansively when you're approaching a woman with suspected acute myocardial infarction, and don't be distracted by the other symptoms, thinking and get blown off course by the greater variation. And try to adopt good thinking habits. There's an order of operations to diagnostic reasoning: hypothesis generation and hypothesis testing. And it's accompanied by probabilistic thinking, but it's an intuitive probabilistic thinking using a heuristic called anchoring and adjusting. You can figure out how much to adjust by thinking about likelihood ratios. And likelihood ratios, I think, that it's a way of incorporating sensitivity and specificity, but it's a dimensionless number that gives you an idea of the strength of new information. I think likelihood ratios are very, very useful, and that creates the ability to do informal Bayesian reasoning, which I think experts do intuitively. But it would be good to inform learners earlier so that they can pick up that skill earlier rather than waiting for years and years to develop that ability. So I'll just end with this quote from Alvin Feinstein, who was one of my mentors when I was a fellow at Yale. He was one of the inventors of something called clinical epidemiology that ended up sort of evolving into evidence-based medicine. He said, Alvin Feinstein said, "For improvement, clinicians must begin to respect the importance of their own thinking." Alvin Feinstein thought that some of the concepts of Bayesian reasoning and these type of things were the basic science for clinicians, and that every clinician should be aware of. And so I'll just end with a quote by Alvin Feinstein. Thank you very much for your attention, and I hope we have some time for questions. And thank you again for inviting me to speak today.
Thank you, Dr. Brush. That was absolutely fantastic. You've given us a lot to think about. That was and kind of highlighted the fact that we do focus a lot on randomized controlled trials and not so much on decision-making research. So this was wonderful. I do have a question. I have several questions while we're waiting for our audience to type in their questions in the chat. Do you think that this concept of typical chest pain versus atypical chest pain, that terminology, we see that a lot in problem lists where, you're trying to communicate to somebody else because you get consulted as a cardiologist and you're trying to communicate that you don't think that this person's symptoms are cardiac. So people will often say atypical chest pain. Do you think that those two terms are even relevant anymore based on, get away from using that?
Yeah, that's a great question. That's actually something that we want to drill down on now, thinking about where to go from here. Because we do have chart abstraction data, and we do have information about who was defined as typical and atypical. So, I think that what is typical? Typical is how close you are to the prototype, really. And so that's not necessarily correct. I agree with you. It does shake your confidence that that's a useful. That's a useful distinction. And clearly in all studies, both of those studies, atypical was seen more commonly in women. So maybe atypical in women, maybe that's typical. And again, in acute myocardial infarction studies, many of those studies are men predominate in the populations. So I think we need to go back and take a second look at that. And that's what we plan to do. We literally are going to take a second look and try to sort that out and figure that out. But I think you're right. I think it shakes your, it makes you wonder whether that is actually kind of a misleading distinction.
Great. Dr. Smith has a question.
Yeah, just a question. When you look at, obviously you showed there's great heterogeneity in a whole variety of phenotypes. How do you incorporate the patient's individual history? So for instance, I work in the field of congestive heart failure. Some patients we can tell are volume overloaded when they have a symptom such as bending over to tie their shoes, bendopnea, or some may have more symptoms related to orthopnea. But we try to get patients to recognize what their pattern is in order to help them with self-care. So how do you incorporate the things that you're studying based upon that individual's prior history of a symptom complex?
That's an interesting question. I think that a conclusion that I would conclude based on our studies is to think more about, and exactly what you're doing. Think more about patients as individuals. Personalize your approach to patients, and rather than trying to categorize them too quickly, and lump them in categories based on population level statistics. I mean, that's basically what we do. We look at population level statistics to figure out, what are the kind of the general characteristics of a population, and then we try to apply that to individual patients. But I think that, thinking about, what we did is kind of thinking different. We looked at how things aggregated individuals, and then how those aggregations are distributed in populations. And so I think you could do that, the same thing with heart failure. What are the most common combinations? What should you be thinking about? And then it may be that there are key, things that are more important in particular patients, that you would sort of focus on. There's also probably sort of a weighting of the symptoms. Clearly chest pain is sort of the anchored symptom in acute myocardial infarction. And it may be that, chest pain and so shortness of breath is the same, it's the anchor with heart failure. You kind of figure out how these other symptoms, kind of aggregate around those anchors, may be a way that we can figure out how we actually think about this. It raises questions. How in the world do clinicians sort through these things, and parse through the the symptoms that come their way to figure out a diagnosis. With that much variability, how does anybody make any diagnosis? And it's because we use intuitive, heuristics. We probably group things and lump things, in the way that a musician lumps things in chords and keys. We do similar tricks, and so it really leads to a lot more investigations, I think, to think about how we do this.
Yeah, I mean, I think one important component is, I mean, we talk about the experience of the clinician, but also I think we need to be considering the experience that that clinician has with that individual patient. That is, I think, one of our heart failure nurses talking to a patient over the phone who knows that patient, who's seen them in the clinic, is probably more likely to get the situation right than someone who was hired by an insurance company or the government, who's located several states away, to be calling the patient up and asking them about their symptoms when they don't know that specific patient. So I don't know how you incorporate some of that into your studies, but I think it's an important part of the experience of the clinician.
That's a great point. It's sort of individualized experiential knowledge. That's a great point.
Any other questions or comments? One thing is that we use symptom research, I think, is just very difficult because, even when we're talking about chest pain, people say chest discomfort. A lot of my women will say, oh, no, I'm not having pain, but it's chest pressure or chest discomfort or unusual feeling in my chest, but it's not chest pain. I've had several people say that. So in general, I feel like symptom research is difficult. And when we make diagnosis, we almost always, listen to the patient, get the history, but then we have ancillary data, like we have troponin elevations, we have EKG changes. So we have to look at, all of it, right, to come up with a diagnosis that is most likely. So any thoughts about, relying on symptoms alone versus symptoms plus your troponin and EKG and everything else that we use? Does that improve on the diagnosis, do you think? Or do you think it's all just history and physical?
Oh, I think that it's definitely part of the two-step process. I mean, I think that symptoms and presenting characteristics, symptoms and physical exam findings are part of the hypothesis generation that are useful. And if you do that first, and then you start ordering the troponin and other biomarkers, particularly, it's a better use. One of the things that frustrates me is that troponins get drawn on everybody right away. And then, as a cardiologist, I'm called to the emergency room every day to, try to create a story that kind of, explains the elevated troponin. But that's really, that's confirmation bias every time. And so it's not exactly the right way to do it. Whereas when you narrow the field, I mean, statistically, by doing things, by being purposeful before you order a test, it's like, stating your hypothesis before you do a research project. What you do is you narrow the possibilities so your statistics are much stronger. And likewise with troponin or any test. And so I think that trying to get some characterization of patients before you draw the troponin is very important. But you're right. Frankly, I think that, when I ask a patient, do you have any chest pain? And they say, well, it's not a pain, doctor. It's more of a pressure. That's a signal to me. I mean, that's makes it much more likely that it's actually angina than if it's something else. And so I didn't talk about how these symptoms were defined, by the interviewers, but pressure or tightness were all included in chest pain. And the interviewers asked it in a way that they, were able to collect all of it, but they were just sort of lumped under the category of chest pain.
Great. All right. Well, thank you so much, Dr. Brush, for your time this morning. We really appreciate it.
Thank you very much. It's been a pleasure and really a privilege for me to talk to you today. And please, if you have any other questions or comments, please let me know. Thank you.
The preceding program is copyrighted by Emory University.